boy. No. Okay, just very quickly, because the built environment is one that really has to be focused on, and I'm just wondering in terms of activities going on within DC as well as in other places as it relates to the connections that have been made, for example, with Dr. Karen Lee here in New York and what she's been able to do with the built environment, as well as the Congress for the New Urbanism, CNU, which has a lot of good toolkits and examples. So I'll just turn that over to you.
Sure. Like I said, as I mentioned before, this is actually becoming a much more highly visible issue within the planning field. There's been a lot of focus on transportation investments because that's the sort of thing that you can sort of kill several birds with one stone. Essentially, you're increasing people's ability to get around the city, but also offering a way for them to engage in healthy exercise and also to improve their health. I think there was something else I was going to mention. Let me think about it. Pass it on.
So I think there are a couple things that are worth saying, and one that was actually prompted by the first panel that I wanted to make a note of to say, which is, as we think, when you look at this mapping and the relationship between socioeconomic status or property values or whatever and health outcomes and access to healthier environments, and one of the real challenges, at least we're facing in the United States, is what we call gentrification. And so as you improve a neighborhood, as you make it more walkable, as you make physical activity more possible, as you improve the quality of the food that is available, those neighborhoods become more attractive and sometimes push out the very people who will be benefiting most from a health standpoint from those changes. And that's a real balancing act that I think is something that we have to figure out how to address. Obviously, if everyone had equal access in every neighborhood, then perhaps that would be a solution. But I don't think the solution is raising property values, because if we raise property values, we're pushing people farther and farther away from those healthy choices.
I have a question. Yeah, this is Adam Dronowski. I have a question here for Ms. Washington-Stern. I've actually been using some of the Washington DC data in teaching my class, so it's very nice to hear about it. I'm of course assuming there's going to be a gigantic difference in property values again between Ward 3 and Ward 8. And so I'm asking, can you do what we have done, and can you then predict obesity rates within pockets of Washington, D.C. using property values and other demographic measures? And then can you track which supermarket people actually go to, having supermarket destination data the way we do?
I don't know if we have that kind of specific supermarket destination data. I think we might be able to make a guess. If you have a certain set of addresses, you can see which grocery stores are close by. I actually was very intrigued by the mapping that you showed during your presentation, and took notes for our GIS division to talk with them about that. I think that we haven't done any kind of mapping that overlaps property values with obesity rates, but Ward 3 does have the highest property values in the District of Columbia. I used to live in that ward. I know how much I paid in property taxes, and I know how much the real estate costs. Compared to Ward 8, it's much cheaper. It's much, much cheaper. And so I think that will be a very interesting analysis to do, and I think there will be some definite overlaps.
I do worry from, at least, from, this is personal experience, and so therefore I'm going to generalize as though it was a study. But I think we need to be careful about identifying particular supermarkets as a way of identifying something about quality of food. At least, certainly there's, if you follow any neighborhood listservs in Washington, if you can have a Safeway in every ward of the city, and the quality of the food will vary by even within a single supermarket chain. And so I think we need to be careful about that. There's one other thing that I wanted to mention from the earlier question that popped back into my mind, which is that one of the things that's happening with these community transformation grants, and there was a predecessor to that called Communities Putting Prevention to Work that was created under temporary legislation, that I think is important and reflects the kind of work that Tanya is doing, but around the country, which was that money was put on the table to have health departments work more closely with other agencies. So for example, in North Carolina, by the state health department and the State Department of Transportation is working together, and so now doing health impact assessments is part of the planning, the routine planning process for the Department of Transportation. And that's something where there's at least a movement in the United States on, which is to have more and more non-health agencies take a health lens to what they are doing, and there's a formal process of doing health impact assessments, which are not horribly complicated and can actually be qualitative from time to time. But at least introducing that as an element of their work so that it changes the culture in those agencies.
Actually, I just wanted to add something to that. The District of Columbia did get one of those CPPW grants, the Department of Health, and through that they created an interagency leadership team involving my agency as well as other agencies that are doing something that has some kind of impact on public health. They've included agencies such as DC Public Schools, our Housing Department, our Parks Department, our Department of Community and Regulatory Affairs, which does business permitting and licensing. And essentially this was really, that was a primary way that I really got very educated about this issue, was through that leadership group. And I think the benefit is that there are some things that the health department can do, and there are things that other agencies can do. And the whole purpose is to try to leverage what everybody is doing and what all of their different investments are in order to achieve this goal.
Philippe Frogel, I would like to stress again the need to target our effort in some segment of the population, not only the poor or people from some ethnicities. And I have a strange story because I'm a geneticist, but when I try to predict at birth the risk of obesity at 5, we did that in a Finnish birth cohort. We validated that in Italian cohort. We sent a paper to New England Journal of Medicine. They said, fantastic, but it should be done in America. So we went to see people from Harvard, did the work, validated, and then the New England sent it to other reviewers. We said, no interest, it's not interesting. And the JAMA didn't even send a paper to reviewers. So my comment is very simple. First, I think it's important that people understand the importance to have some kind of prediction of the risk of childhood obesity. And I'm positive, I can discuss with everyone here, that there's some very simple thing done by any nurse to predict the risk and to have, say, 10%, 15% population. And with an interesting thing. Secondly, it should be adapted to every population, which means that, for instance, smoking, women smoking is not the same important in some population compared to others, and should be, which means that we need to have a birth cohort to do the job in a specific population, and then we try to have the algorithm, because the algorithm prediction is different in Finland or in America or probably in Asia, and then we have to test the usefulness to have that and to concentrate the effort on this population. So we need really a coordinated effort, because I'm totally sure that it's easy to do the job, but we need to have people convinced that it's important to predict what are the families and the newborn and the infant who are really at risk, and to concentrate the effort on these people. But scientifically, the scientific community, the editors, the people at the government should coordinate the effort for that.
Maybe I can answer to that. I completely agree also, and I think that actually the situations are quite different. I know Adam Dronowski has studied also in Paris, but in Europe, where the social disparities in general are much smaller than they are here, there's also much less health inequality. And in fact, in the countries in Scandinavia as well as in the Netherlands, we see the strongest increase in the prevalence of obesity in highly educated girls. So that's something we should not forget. It's not just a problem of the social disadvantaged. Of course, social inequalities are important, but if we leave out all the sedentary girls who sit behind screens and drinking, the wrong kind of beverages and are sedentary and having fast food, we are missing the point. So it's not just that. I think branches out, I think, and that's the idea of IPOD, to all of the communities. It doesn't matter where you are, but particularly also that we should not forget that social disparities in countries are the driving force for non-communicable disease.
I guess I'd just add one very quick thought, which is there's a balance there, and certainly targeting can be very helpful, and doing the right targeting can be very helpful and multiplies the return on investment, because obviously if you're targeting your investment on those who need it most. But I think going back to the first panel and the discussion around behavior and culture, if you're not doing this on a community-wide basis, then you're not changing the culture in which that cohort is living and operating, and then you may be undercutting that targeted investment.